Can you see it now?
Yes.
Okay.
Okay, we'll start now. But if you can go to the first slide. To the title slide, yes. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Thank you everybody for joining us in this webinar. We're going to talk about an important disease that is really sneaking up on us. We didn't think that a few years ago that we had as many cases as we that are diagnosed these days, but it seems that probably we were missing a lot of these cases of cardiac amyloidosis. And in fact, you know, the notion of paying more attention to the management of heart failure patients in general in Saudi Arabia has gained a lot of interest, especially at the Ministry of Health level, and of course in the other healthcare sectors, because of the number of cases that are diagnosed yearly, the number of cases that we have ongoing management for, and the number of cases that need advanced therapies. And probably we need to refine our way of managing this sick group of patients, and part of that management is really reaching the accurate diagnosis and managing these patients in a better way. So we have two distinguished speakers today. First of all, I want to introduce my colleague. He's going to chair with me this session, Dr. Kamal Ghalayini. He's a professor of cardiology at King Abdulaziz University, and he is also an expert in heart failure management. It gives me a great honor to introduce our first speaker, Dr. Baha Fadil. He's a consultant and section head of adult cardiology and director of echocardiography laboratory at the Al Faisal University. He's a professor of medicine as well there. And it gives us great honor to have him tonight with us in this webinar. So Dr. Baha, the floor is yours, and we'll be interested to hear what you say. And after the two talks, we'll take some questions, inshallah.
Thank you so much for your presentation. Good evening, everyone. I would like to welcome you to this interesting webinar about cardiac amyloidosis. I hope you'll find it interesting as well as instructive and useful for your practice. For the next 20-25 minutes, I'll be discussing a few aspects of this disease. First of all, I'll try to define what is cardiac amyloidosis. I'll discuss briefly the different types of amyloidosis. I will explain to you how does amyloidosis develop. I'll touch a little bit on the clinical aspects of the disease and about the red flags of cardiac amyloidosis when to think of it. I'll discuss as well ECG findings in cardiac amyloidosis, kind of part of the workup of the disease. I'll touch a little bit on the genetics of the disease, and then I'll give the kind of my turn to Dr. Daniel Moxley, who's a colleague at King Faisal Hospital, and she's going to be discussing further aspects of workup, which is cardiac imaging. I want to start by showing you the three patients we have seen at our institution over the past couple of years. All three of these patients have left ventricular hypertrophy. As you see here, patient 1, you can see there is mild degree of left ventricular hypertrophy. Unfortunately, the video is not playing perfect, but you can see there's mild hypertrophy. Ejection fraction is normal. Patient 2, you can see here worse hypertrophy, and the ejection fraction is kind of borderline reduced. The third patient here had even worse hypertrophy, and ejection fraction is severely reduced. So patient with mild hypertrophy, normal left ventricular ejection fraction, patient with moderate to severe hypertrophy, borderline reduced ejection fraction, patient with severe hypertrophy and severe reduced ejection fraction. All these three patients have in common cardiac amyloidosis. All three have cardiac amyloidosis. What I think is very important for you to keep in mind is the fact that this patient was diagnosed on time. This patient has mild hypertrophy, and this patient has normal LV ejection fraction. This is where when you want to diagnose the disease. We're diagnosing this patient a bit relatively late. Since hypertrophy is quite significant, ejection fraction is beginning to decrease. This is a little bit late in diagnosing the disease. This patient
excuse me, Dr. Baha, can I interrupt you? Your voice is not really very clear. So I don't know if
okay, I can. Let me just try something else.
Now it's better. Now it's better, much better now. It's much better.
I don't know if you can hear me better now.
Yes, this is better.
Okay, perfect. So let me just go back maybe a minute in time and mention that patient number 1 here has a left ventricular hypertrophy, normal left ventricular ejection fraction. This is where we should and we want to diagnose cardiac amyloidosis. Patient 2 has significant hypertrophy, already ejection fraction is beginning to drop. This is a little bit late in diagnosing the disease. The patient number 3 here to the right has severe hypertrophy and left ventricular ejection fraction is severely reduced. This is quite late in the disease. We want really to recognize patients here quite early in the disease, since here intervention makes a difference in patient outcome. In patient number 3, intervention probably is not going to make much difference to this patient. Now, the slide will summarize to you when we used to be about 10-15 years ago in the field of cardiac amyloidosis, where we are now. Give you a bit of insight about the disease. It took me a while to think of the slide and to make it, but I think it's a slide kind of start to talk with. About 10-15 years ago, this is then and where we are currently now. We used to think that the disease is quite rare. In fact, the disease is much more common than we first believed. Disease awareness used to be poor in the past. It's much better now. Partly, this is also partly because lots of research being done on the field about cardiac amyloidosis. Lots of papers being published about the disease. Lots of being translated about the disease. The genetics of the disease.
Sorry, Dr. Baha, to interrupt again. I'm sorry to interrupt again, but the voice. When you moved away a little bit from the computer just a minute ago, it was much better. I don't know. Can you? I don't know. Maybe. Let's test the voice a little bit more.
I'm sorry using headphone. In fact, I'm using a headphone.
The position when you have your head a little bit away from the computer, I think it gets better.
Okay.
Can you talk now?
Yes. Can you hear me better now?
Yes, that's much better. That's much better. Yes.
Okay.
I'm sorry about that.
No problem. So the genetics of the disease used to be poorly understood. Now they are much better understood. Diagnosis-wise, in the past we used to think that we should do an endomyocardial biopsy to diagnose the disease. Now the diagnosis is most of the imaging and immunoglobulin assays. ECG in the past we used to think that patients should have low voltage before we think of the disease. Now we're not talking anymore about low voltage, we talk about relative low voltage and pseudo-infarction.
Actually, Dr. Baha.
Yes.
I'm sorry to interrupt one more time. Sometimes when you move the mouse, the sound goes away. I noticed this, and because now we have a lot of voice, will be better.
In fact, I can't hear you myself. I cannot hear what you're saying myself. I think there's a problem. I think there's a problem with the audio.
Not move the mouse a lot. Can you hear me now?
Yes, I can hear you, but I really don't think it has to do with the mouse. I think it has to do that the audio is not good. I think the voice comes and goes, and I cannot hear you many times when you're talking. I cannot hear you, in fact.
Okay, okay, you can continue now, and we'll see how it goes.
Okay.
Thank you, Dr. Wahab.
Now, okay, thank you. So regarding biomarkers, in the past, we knew nothing about biomarkers. Now we really know that they have important role in prognostic stratification. Imaging in the past used to be purely echo. Now we're talking echo, we're talking multimodality imaging with echo bone scan and cardiac resonance imaging. In the past, the therapy used to be only supportive. Now it's supportive and disease modifying. Management in the past used to be physician-based. Now it's multidisciplinary team-based, and we're going to be discussing this later. I think other speakers about this. And the outcome in the past we used to consider quite poor. Now the outcome is much improved, particularly with disease-defying medications. There's certainly amyloidosis. If you do a PubMed search and you enter the term amyloidosis, you can see here that from 1980 till about 2010, so over a 30-year period, there have been only mild or slight increase in the number of publications in PubMed about cardiac amyloidosis. From 2010 to 2020, you can see there's a significant increase in the number of publications. This tells you how this disease now is being researched, how much we know about the disease than we used to know in the past, and the interest that this disease carries nowadays. However, there are still many challenges in diagnosing amyloidosis. This is an interesting paper from the Amyloidosis Research Consortium, looking at 533 patients with AL amyloidosis. If you look at the time from onset to symptom diagnosis, in most patients, it took more than 6 months to diagnose the disease. In fact, in some patients, it took 2 to 3, even more than 3 years to diagnose the disease. If you look at the number of physicians visited before establishing diagnosis, the biggest bar here, about a third of patients, it took them 5 or more physicians before amyloidosis was diagnosed. If you look here as well to the left-hand side and you see the organ involvement, you can tell that the heart is much more involved than other organs. The problem is, despite that, cardiologists diagnose the disease only in 19% of the time. So nephrologists and hematologists, oncologists did much better than cardiologists in diagnosing the disease. So certainly there is an important message that there is room to further educate cardiologists and to raise awareness of the disease among cardiologists. We need to do much better than what you see here in this publication. Now, what is amyloidosis? Let's start talking a bit about the disease itself. And amyloidosis refers to the extracellular deposition of insoluble abnormal fibrils composed of misfolded proteins. This leads to alteration in tissue structure and impairment in organ function. And it's important to realize that amyloidosis could be acquired or it could be hereditary. Depends on the type of amyloid protein that is involved. Now, if you look at the organs that are involved with cardiac amyloidosis, excuse me, you can see here the heart is quite often involved, but this also depends on the type of amyloidosis. The gastrointestinal system, again, can be involved as well, and symptoms, GI symptoms that come in this disease. The peripheral nervous system down here, you can see it can be involved. Autonomic neuropathy can develop in patients. Hypertrophic syndrome is important, very important to keep in mind, particularly if bilateral. It's not uncommon in this disease. It's one of the earliest manifestations of cardiac amyloidosis. Often the disease particular transthyretin amyloidosis manifestation by few years. So it's an early occurrence in the disease. The kidneys can be involved as well, can have involvement of the central nervous system as well as eye involvement. So as you can see, this is multi-organ disease, and this is why there's a requirement for a multidisciplinary approach to diagnose these patients. In the heart, amyloidosis fibrils, we say they don't discriminate. They sit everywhere. They sit in the myocardium, leading to heart failure. They can sit in the pulse, particularly stenosis. They can sit in the conduction system, leading to cardiac arrhythmia, as well as tachyarrhythmia. They can sit in the pericardium, or the pericardial fluid. They can as well sit in the coronary artery. So any part of the heart can be involved with amyloidosis. Now, what are the types of amyloidosis? Amyloidosis is classified according to the nature of the fibril precursor protein. The most common type of amyloidosis I think we're encountering nowadays, the next slide we refer to as ATTR amyloidosis. ATTR amyloidosis will be hereditary due to the position of mutant transthyretin protein, and this is transmitted in a autosomal dominant manner. ATTR amyloidosis will be as well acquired due to the position of wild-type transthyretin. The second form of amyloidosis is light chain. We refer to as AL amyloidosis due to the position of fast chain immunoglobulin, second cytoplasmic sensation. And the third type of amyloidosis is a big bag of things. This is the position of other proteins in organs, can occur as well in the heart, and can lead to amyloidosis. These proteins are numerous. This is only a very short list of them. For example, serum amyloid A, lipoprotein A, and so on. They can deposit in organs, lead to amyloidosis. As I mentioned, transthyretin amyloidosis now is more common than all other forms of amyloidosis, followed by light chain amyloidosis. Now, how does amyloidosis occur? What is the mechanism of amyloidogenesis?
Dr. Baha?
Now, yes.
Sorry to interrupt you, doctor. But doctor, your voice is not clear. A lot of attendees, they are complaining. If you can just sit a little bit far from your computer, so because when you start talking, it's become like a lag and this maybe internet issue. But we can see your video is working perfectly fine. Only the voice.
Okay.
Or if you have another, is your internet connection good, Dr. Baha? There, the signal is good, everything is fine from the internet point of view, because your slides are perfect, but your voice, we cannot hear you.
Okay, I really don't know what to do about this, unfortunately.
Now,
this is good now. This is a good position now there.
But
okay, should I go back 1 or 2 slides or no?
It was since the
yeah, please go back to 2 slides, you know, I noticed that even I was in a webinar just a couple of days ago. When somebody moves the mouse, it affects with the laptop. It affects the transmission of voice.
Okay, I will not move the mouse. I promise I will not touch the mouse.
Okay.
Okay, so let's go back, talk a little bit about amyloidosis deposition in the heart. We say classically that amyloid fibrils in the heart do not discriminate. They sit everywhere. They sit in the myocardium, leading to heart failure. I just need to minimize this. Excuse me for a second. I have to move the mouse for a second. They lead to heart failure. The fibrils can deposit in valves, leading to stenosis. They can deposit in the conduction system, and often they deposit in the pericardium, as well as the coronary arteries to myocardial artery.
I think we have the same problem. So I don't know, Kunuz Ritaj, do you have any solution, any technical solution there?
No, doctor, because it's connected from his computer. We cannot do from here. I cannot, like, I don't have any idea about this because this is first time. Uh, because when I saw this one, when he's moving the mouse, it's a problem appeared. But he tried in the beginning. Now, when he started again, it was perfectly fine. But after 30 seconds, started again.
So what do you suggest?
Uh, could we go with Dr. Dania and until Dr. Baha can try and log in from another laptop if he has?
Unfortunately, I don't have any other laptops.
You know, your voice like this is good. If you, I think the minute you start moving the mouse, or you disconnect the mouse completely, maybe that's the.
I mean, I don't have a mouse connected. I don't have a connected mouse. This is just a mouse built in the laptop.
Ah, okay.
I mean, this is not the first time I mean, the first time I used Zoom, I never had a problem like today problem. This is the first time I have such problem.
And now we can.
Yeah, sometimes there are glitches. You know, your voice like this is perfect. Yeah, but I don't know what happens. Then suddenly it just goes back and forth. Let's continue. Let's continue, Dr. Baha, and let's see where we go.
Okay, so amyloidosis is classified according to the nature of the precursor protein that gets deposited. You can see to the left side of the slide the ATTR amyloidosis, which is due to deposition of transthyretin protein. It could be either hereditary or acquired. The hereditary form is due to deposition of a mutant transthyretin and transmitted dominant manner. It could be as well acquired, and this is due to the deposition of wild type transthyretin. In the middle, you see the light chain, or what we call AL amyloidosis, which is light chain globulin due to plasma cell excretion. This is the second most common cause of amyloidosis after transthyretin amyloidosis. To the right side of the screen, you see other types of amyloidosis, which are due to deposition of proteins, and it's a very long list of such proteins, and you can see few of the proteins here that can lead to amyloidosis. These represent the least common form of amyloidosis. Now, how does amyloidosis occur, and how these proteins deposit in tissues? We really don't know the full story here, but I start talking a little bit about wild type transthyretin to the right. Transthyretin is produced in the liver at serum, and you can see 4 molecules of transthyretin stuck together. And we call it transthyretin because it transports dioxin and retinol. So transthyretin, why this protein called transthyretin. Transport in the dioxin and retinol. For some reason, we don't really understand why the tetramer sometimes associated with these polymers misfold and they aggregate together and they deposit in tissues as insoluble protein, and they deposit between cells, not inside cells. So it's an extracellular in organs, and they lead to the disease.
I'm sorry to interrupt you again, Dr. Baha. Can you please, I don't know, stop sharing, or maybe can you please log off and rejoin? Stop sharing, log off and rejoin again, because you know it's not working.
Okay.
Okay. Can you now try talking like that and share again?
Okay, so I shared again.
Yes, that's better. I think that's better. Okay, you can continue, Dr. Baha. Let's see how it works now.
Okay, so to the left-hand side, you can see the light chain immunoglobulin. The same thing happened here. Immunoglobulin is produced by plasma cells. For some reason, they misfold, they aggregate, and deposit as well as soluble proteins, leading to amyloidosis. To touch base here about the clinical stage of amyloidosis and the risk factors and I cannot move my slides now. Okay. Now, what are the clinical reflex in cardiac amyloidosis and when should we think of cardiac amyloidosis? We have to consider cardiac amyloidosis in any patient who presents with symptoms of heart failure. Patients may present with exertion fatigue, weakness. Sometimes patients have predominance of heart failure symptoms. They may have anxiety. Physical examination is the only sign on examination that may make one think.
Sorry, Dr. Baha. I think the problem is probably the internet connection you have. So if we can, I'll have to stop you there, and maybe Dr. Dania can start her talk.
No, okay, sorry. Can I suggest something for Dr. Baha? Can you just stop sharing video? You just take out your video. You mean and just talk in the computer without putting the headphone in your.
I'm not using headphone.
Okay, try to take out just your video. Stop your video please. الكاميرا شيل الكاميرا وخلي بس السلايدات. خلي الشيرنج وشيل بركي بخف الانترفيرنس.
Okay.
Try this one and keep. لأنه actually Dr. Adel, what I'm talking is a complementary of what he needs to finish his talk to be able to talk about imaging. Sorry about that.
Sure. Yeah, let's try that. Yes.
This is life. It happens. What we can do.
Okay, so let's try now without video. Okay.
Yeah, this is perfect. Okay,
so let's talk a little bit, go back to the Q-small sign. This is a sign, this is dramatically increases in special situation that occurs with restrictive cardiomyopathy and being restrictive cardiomyopathy. This sign maybe this is probably the only physical sign, the only physical cardiac sign that one may see, which is now let's start talking about as you can see, most of these patients are made. They are older than 60 years. Patients may they may present as well with a new diagnosis. They may be diagnosed as hypertrophic cardiomyopathy. So anytime you hear of someone having hypertrophic cardiomyopathy diagnosed at an older age, you should certainly consider that this is not sarcomeric hypertrophic cardiomyopathy, but rather cardiac amyloidosis. A patient may present with an AV block requiring a pacemaker, but as well there are some extra cardiac signs one should think of cardiac amyloidosis when we encounter them. One of them is spinal stenosis. Transthyretin can deposit around the spinal cord in the dura and cause compression of the spinal cord, and patient can have spinal stenosis. A patient can have as well rupture of the biceps tendon in transthyretin amyloidosis, so one should certainly look for that. Looking to the left side of the screen, this is the light chain amyloidosis. Two very characteristic signs, though they're not common, are microglossia. You can see the patient with a large tongue, as well as periorbital purpura. Both are quite characteristic of light chain amyloidosis. Patients can have orthostatic hypotension due to non-autonomic neuropathy. This can as well occur in patients with transthyretin amyloidosis. Patient can present with nephrotic syndrome due to AL amyloidosis particularly. They can have something called the deltoid pseudohypertrophy, where you can see in the picture here, like increase in the size of the deltoid muscle bilaterally. Now, two symptoms that are common, or two manifestations are common for AL and transthyretin amyloidosis are carpal tunnel syndrome, particularly when they are bilateral. One should think of amyloidosis, as well as peripheral neuropathy. So if you keep in mind these manifestations I've mentioned to you, any of these manifestations should make one think of cardiac amyloidosis if they are encountered in your patient. Now, I want to touch base a little bit, discuss ECG in cardiac amyloidosis. This is the first test we do as a workup for a patient with cardiac amyloidosis. The first thing really we consider whenever we think of cardiac amyloidosis, the first test to do and the first thing to look for is an electrocardiogram. Now, in the old days, we used to think that low QRS voltage is the thing to look for on the ECG. Well, it is still something to look for, but it is not as common as we used to think. This low voltage is due to the deposition of amyloid fibrils between cardiomyocytes, not inside the cardiomyocytes. So we don't have hypertrophy on the ECG. In fact, the myocyte is strangulated by the amyloid fibrils, and this leads over time to low voltage. Low voltage is more common with AL amyloidosis, as you can see, 60% of AL amyloidosis versus about a quarter of patients with TTR amyloidosis. But as you can see, it has low sensitivity and low specificity. And the absence of low voltage should not exclude amyloidosis. Therefore, it's not quite useful. It's not useful as a screening tool. What we should think instead of low QRS voltage is we should think of a disproportionately low voltage for the degree of wall thickness we see on echo. So there's we should think of the discordance between the wall thickness and the QRS voltage. You can see to the left here, patient with, for example, hypertension, hypertrophic cardiomyopathy. They have high LV mass, and you can see they have high QRS voltage. Patients with amyloidosis tend to have, in fact, more muscle mass, but you can see their voltage is quite low. You can see this patient here on echo, there's significant degree of concentric hypertrophy. You look at the ECG, there is no low voltage. But what there is a disproportionately low QRS voltage for the degree of hypertrophy you see. For the hypertrophy we have here in this patient, we'd expect to see high voltage in the limb leads. You can see here the limb leads have quite low voltage. So this is the thing we should look for. We should not look for low voltage. We should look for disproportionately low voltage for the degree of hypertrophy. Now, a more important sign than low QRS voltage is what we call a pseudo-infarction pattern. Up to about 70% of patients with amyloidosis have a pseudo-infarction pattern. And it's important, you can see here in the middle ECG, you can see a QRS pattern in lead V1, V2, V3. This patient does not have an anterior wall myocardial infarction. This patient has cardiac amyloidosis. So often when we look at such an ECG, we read it as a myocardial infarction. But we should think of amyloidosis when we see such an ECG and the patient has no history of coronary artery disease. If on echo there are no wall motion abnormalities, and on the myocardial perfusion study, there is no evidence of infarction. So not all pathological Q waves imply infarction. Some of these patients have cardiac amyloidosis. To the right side of the screen, you see an ECG and you see the patient has atrial fibrillation. AFib can happen in up to about half of the patient with TTR amyloidosis. This patient has as well right bundle branch block and left anterior fascicular block. These patients can have bundle branch block up to 20% of them. They can have up to 20% as well AV block. But also what you see on this ECG is LV hypertrophy. Look at the high voltage in, for example, lead AVL. Well, you can see up to 10-15% of patients with cardiac amyloidosis having hypertrophy, particularly transthyretin amyloidosis. Because these older patients, they have hypertension, they may have aortic stenosis. So the idea is here, when you see high voltage suggestive of hypertrophy, you should not exclude cardiac amyloidosis just because there is high voltage. You will see from time to time patients with amyloidosis who have high voltage. So I'm going to summarize quickly and bring this kind of my presentation to an end. When to suspect cardiac amyloidosis. You can see here in the middle, patient with heart failure with preserved ejection fraction should make one think of cardiac amyloidosis. Above it, degenerative aortic stenosis, particularly when there is low flow, low gradient. Below it, atrial fibrillation, particularly when there's an embolic event, because patients with amyloidosis have a high risk of thromboembolism in the setting of atrial fibrillation. When we do an echo and we see a thick heart, we should think of amyloidosis when there's concentric hypertrophy, even if the patient have hypertension. But often, unfortunately, we mistake it for hypertensive heart disease, for hypertrophic cardiomyopathy, or for other restrictive cardiomyopathies. We should think of it when we have an ECG with relatively low voltage, or particularly pathological Q waves in the absence of full motion abnormalities. Such patients can have low blood pressure due to autonomic neuropathy. But we should think of it particularly in a patient who's hypertensive, in whom we have to start reducing medications, reducing antihypertensive medications, because their blood pressure is going lower and lower. This is due to autonomic neuropathy. Should make us consider amyloidosis. Patient can present with AV block. They can present with peripheral neuropathy or nephropathy. You should think of it even if the patient may have diabetes mellitus. An important feature is carpal tunnel syndrome, particularly when bilateral. This is really something important, and consider the other manifestation I've mentioned to you as well. A quick word about genetics. I want to tell you that there's a relationship between the genotype and the phenotype. You can see here to the right, in red, you can see mutations that lead to predominant cardiac manifestation of the disease. To the left, you see mutations that lead to predominantly neurological manifestations of the disease. So there's a relationship between the mutation and the manifestation. Some mutation cause predominantly cardiac involvement, other cause predominantly neurological involvement, and others can cause one or the other or both together. So this is really important to keep in mind. Why we do genetics? We do genetics in these patients for few reasons. One of them, distinguish, for example, TTR amyloidosis from other subtypes, but importantly as well to differentiate between wild type and inherited TTR amyloidosis, to look for genotype phenotype correlation, because as I mentioned, some genes cause one phenotype, cardiac phenotype, for example, versus another neurological phenotype, and to look for family screening. Now, this slide is quite important to keep in mind. As you can see, with progression of the disease, the patient functional status in green kind of takes a while to decline, with myocardial infiltration in red progressing. So it takes quite a bit of infiltration of amyloid in the heart before the patient's functional status starts to decline. But as the functional status decline as well, you can see the ejection fraction declines, and you see the symptoms developing in such patients. And a bit later, you start seeing these markers. Dr. Marty will talk about BNP and troponin going up. This is a slide just to show the journey through diagnosing cardiac amyloidosis. We really need to take a good history, do a good physical examination. Dr. Marty will touch about laboratory testing. We need to evaluate these patients cardiac-wise, ECG. Dr. Marty will discuss echo and CMR, and someone else will talk to you about bone scans tomorrow. Hematological evaluation as well as other organ evaluation, neurological, nephrological, and other organ evaluation are important in these patients. Sometimes we need to do tissue diagnosis. Some other times we do not need to. Typing of amyloidosis, we may need to do it at times. And I think the genetics, as I mentioned, are quite important, particularly in transthyretin amyloidosis. And I'll bring this to an end. Before this pandemic, we were kind of finalizing the steps to start a hypertrophic myopathy clinic at our institution, targeting mainly patients with cardiac amyloidosis. As you can see here, this is, as I mentioned, this is a multi-organ disease. It requires a multidisciplinary team approach to take care of patients. You see here the cardiac clinical service involved echo lab, electrophysiology, nuclear medicine, cardiac MRI. We need other teams involved from neurology, genetics, nephrology, hematology, as well as some other services. I want to apologize for the audio during my presentation, and I hope you were able to hear most of what I said. And Dr. Marty will take it from here and discuss imaging with cardiac.
Thank you. Thank you very much, Dr. Baha. And you know, the last part was perfect, and we heard you loud and clear. And I would like to thank one of our anonymous participants here, who told me that if I keep my mic on to mute my mic, the sound becomes clearer. He was great in noticing that. So this is what I did, and this is what fixed the situation. I don't know why. I have no idea, no clue why this happens, but this is what happened. I'll leave it now to Dr. Kamal to introduce our next distinguished guest.
Thank you very much, Dr. Adil and Dr. Baha. Very detailed and enormous information has been presented, although difficulty with the voice here and there, but the slides were quite informative. Thank you again. And now it gives me a great honor to present Dr. Dania Moti. Dr. Dania is a consultant cardiology at King Faisal Specialist Hospital and Research Center in Riyadh. She is also a professor of medicine at Al Faisal University. Dr. Dania comes from almost 20 years of experience in cardiac amyloidosis in Limoges, France. And to me, I think Dr. Dania is considered the reference of echocardiography when it comes to cardiac amyloidosis in the kingdom, probably in the region. So here we will find her presentation about imaging tools for diagnosis and prognosis on cardiac amyloidosis. Dr. Dania, the screen is yours.
Assalamu alaikum. I don't know if you can see my screen. I would like to thank you, Kamal, for this kind introduction. I would like to, I'm happy to meet Dr. Tarar for the first time, Dr. Adil for the first time. And I would like, without further delay, to thank first the Saudi Heart Association for giving us the opportunity to share with them our passion and our knowledge about this rare disease and very, as you will see, and as Dr. Baha told you, very fatal, probably fatal disease. Again, I would like to thank, I would like to thank our amyloid team from King Faisal Hospital, because without them, we could not start I would say, the program. And as Baha showed you, and I will show you again and again, that this disease cannot be managed solely. We need to have a team, and we call it the King Faisal Amyloid team. And also, we need our family, and because of the hard work and very, very hard interrupted work of all team from Pfizer, as you can see, starting by Dr. Islam, who came to us and proposed his help and technical help. We were able to go through all the region, whether in the Gulf area, in Lebanon, and Jordan. And I would like to thank really, really from the bottom of my heart, everybody, because we were able to build something since 1 year now. So as Baha told you, amyloid is a systemic disease, severe disease with very often underdiagnosed or misdiagnosed. Because why? Because the diagnosis is not easy or straightforward, as you will see. It can simulate many other diseases. Rapids used to call it, it's a great pretender. And there are several actually myocardial disorders that can phenocopy cardiac amyloidosis. Moreover, why we need to know about it? Because cardiac involvement has major impact on outcome, and most of these patients will die from cardiac causes. I don't know. Are you hearing me? Are you hearing me well now? I'm just very stressed out. So
no, it's super perfect, Dr. Dania. Keep going. Very clear. Thank you.
Excellent. So I would like I didn't take the responsibility while Baha was talking to take over his slide, because I don't know if I told you, we had many the opportunity to work together for the last years, doing many educational webinar lectures and meetings, and so we have our slide almost together. So this is basically, I think I just want to spend maybe 1 minute, if you allow me, because this is very important. If people understand that amyloidosis is not one disease but many diseases, they will understand many things later. So as Baha told you, but the voice was not clear, we have mainly almost like maybe 100 precursor of amyloid fibrils, but the most important one are 3 of them. We have the Transthyretin amyloidosis, which will deal at the wild type, mainly will deal in cardiology and our elderly population and the HFpEF population and the aortic stenosis, as he told you. And it could be acquired, what we call the wild type or the senile, because in the past it used to be like for elderly patients, but now we can see even younger ones. 60 I consider as young now, so it's we can have in our experience this type of patient. And you have the hereditary one, which present most of the time with neurological symptoms in the beginning, and 5 to 10 years later they will develop cardiac manifestation. And most of them, the phenomenon is the same. There is deposition of mutant abnormal protein, which will transform on fibril amyloid different organs. You have from the other side the light chain amyloidosis. We call it the cancer of this amyloidosis. It's an emergency. People can die within 3 months if we don't do nothing. It's a leukemia basically. So really the emergency and the take-home message is to look for the light chain amyloidosis and to rule it out before any further action. And this is again a deposition of abnormal light chain. The precursor is different than the TTR1. It's a light chain coming from the bone marrow due to plasma cell dyscrasia, the beta 1. And this one gives again abnormal fibril amyloid that will have a particular conformal spatial conformation in the space, and they will go and they will form this spatial amyloid fibrils that will go to the organs. And of course, you have the other type of amyloidosis from the other, like the fibrinogen, zelzolene, the beta 2 microglobulin. So this is very important to know that there's many diseases hidden behind word amyloidosis. Now I will go back to my presentation. So let's start with the first case, just to show you how it could be a very great pretender. And I want people to look very carefully to this echo. This is a 50-year-old man with no cardiac risk factor, developed rapidly progressive heart failure associated with neurological disturbance and dysarthria. He has a pretty good blood pressure. The heart rate was 80 per minute. The lab test was showing NT-proBNP very high, more than 15,000. The troponin was normal. The renal profile was acceptable. The EKG, I don't have it here unfortunately, but trust me, it was sinus rhythm with left ventral branch block and no specific ST change. Now, I want you to look because I want to ask you one question about it, and look at the echo carefully. You can see the parasternal long axis view, the parasternal short axis, the 2-chamber, the 5-chamber, and the 4-chamber. And here I give you the measurement because it was small. The LV and diastolic diameter was 56. The interventricular thickness septum is 30 millimeter, and the GLS was low, minus 9.6, and I will show you the normal values later, and with no specific pattern. So the question is, if Bilal is here, the question is, what's your hypothesis regarding this patient? Does he have severe cardiac sarcoidosis? Does he have severe advanced stage of cardiac amyloidosis? Do you have does he have iron overload, hemochromatosis, or does he have severe advanced stage of Friedreich ataxia or Fabry disease? Or maybe I'm not sure. I prefer to respond at the end of my conference. So please, Bilal, can you pull out the question and see me what people are responding here? So I will give you only 10 seconds because we are short of time, and I will do my best not to delay you very much. So can you give us the answer now, please, Bilal, for those who respond already? Just to have an idea, it will help us to. So basically, people are mixed up. So, but I'm happy that 50% of them are very wide and they don't want to respond and they will wait. So I will show you basically. Some people responded cardiac amyloidosis. Why not? And actually, to be honest with you, this patient has been came to in France in our center because we are referral center in National Referral Center for Amyloidosis. So many people used to come from all over the country, and I used to think that it was very common actually because I used to see almost 3 or 4 patients per week. So and in my mind, I would see amyloidosis everywhere, and I used to call me Madame Amyloidosis. So basically, this patient came for that, but actually he does not have amyloidosis. I will show you why he does not have. Now, tells you that this diagnosis cannot be made solely by the echo itself. We need a global integrative approach, and it's really mandatory in cardiac amyloidosis. We need, as Baha told you, extensive clinical assessment, and I give you some clues on the clinical assessment of this patient. He has neurological disturbance, he has some ataxia, he has some dysarthria. So this will help. If we did not ask or we did not listen to the patient, would not have having, because the echo was maybe, yeah, it could be amyloidosis, but we have another clue, which I will tell you later about it. So we need the echo, of course, but we need the biomarker. I will tell a word about them, and the EKG, as Baha showed you, and the cornerstone will be bone scintigraphy in our topic today. And of course, I will give you a word about the CMR and when to do biopsy. So echo, I call it always the queen in amyloid heart disease. It is the most widely used imaging modality to detect cardiac involvement with a very good sensitivity, but maybe a lower specificity. what to expect from echo. And I don't need to make a lot of compliment about echo. Everybody knows that it gives us a lot of morphological information, hemodynamic information, diagnostic information, but also prognostic information. So really, we have to start with it. And according to the guidelines and the recent consensus paper that I highlighted, this is the second step after EKG and after clinical assessment, demographic assessment and EKG. You have to perform TTE when you're dealing with any type of cardiomyopathy. So cardiac amyloidosis is usually described as restrictive cardiomyopathy, which the common physiology is characterized by abnormally stiff myocardium, which could be idiopathic, idiopathic restrictive, or by abnormal substance going into the myocardium, such as hemochromatosis, the iron overload, or the amyloid fibril we are talking about today. This leads to abnormal relaxation and abnormal LV filling pressure, and ultimately it also leads actually to systolic contractile dysfunction, which could be maybe hidden in the beginning. The immediate hemodynamic consequence is a rapid increase in LV pressure, which is associated with no or small increase in LV volume, and that's why people get head symptoms actually. So we have a very rapid increase in LV filling pressure, but no increase in the LV volumes. The amyloid heart also was described as typically as diastolic heart failure, as is written in this review from Matthew Morer in the United States, and they call it, and the TTR is a really typical, a prototype example of diastolic heart failure. But what I want to show you that all type of mitral pattern are possible in cardiac amyloidosis patients. We don't have only the restrictive pattern. You can see the pseudonormal grade 1 here, you can see the pseudonormal type 2 here, and you can see the restrictive maybe at late stage of the disease. So if you rely only on the restrictive pattern, you may miss a lot of patients. This is part of that echo and part of the definition, but it's not the most common one. I will show you. You have also the dilated LA, but however, the decreased E prime at the mitral lateral or septal level and the S prime, the systolic waves at the mitral annulus are constantly present with increased E over E prime ratio. So this study tells you exactly what I've just told you, that if you look only at the restrictive pattern, you will have only 35% and will have at the presentation with cardiac amyloidosis this disease. However, if you look at the systolic parameter, 93% of these patients with cardiac amyloidosis have actually abnormal systolic longitudinal function as represented by the longitudinal strain or represented by the S prime for those who cannot perform global longitudinal strain. Please note here that 34% only has low ejection fraction, but we can see here if you look at the longitudinal strain, you will see more systolic dysfunction. Now, the definition of the typical cardiac amyloidosis, they rely only on the mean wall thickness more than 12 millimeter, as written here in the consensus paper from Palladini in 2012. It was dealing with light chain amyloidosis, but initially in the absence of other cause of obvious cause of hypertrophy. However, if they add later the association with increased BNP or troponin to be able to define the cardiac involvement in cardiac amyloidosis. However, I can tell you, this is in my practice and in our experience, the mean wall thickness is not really, for me, is not enough. Why? Because it gives you the definition that we have thick heart. Okay, but how to better identify? And this question, I had it actually from Kuwait one time. People telling me, okay, you're telling us we have thick heart, but how can I know if it's Friedreich ataxia? How can I know if it's Fabry disease, Danon disease? And I think the other clue that you have to look at it is the size of the LV. Remember, I showed you the first case, the size of the left ventricle was 56 by M mode. And if you do the volume, probably the volume would be mildly dilated. So this patient, usually, according to my experience, I've seen maybe 300, maybe 400 patients with amyloidosis, they really, the more they get sick, the more the ventricle is become small. So this is another clue. I'm advising you to look at it. The people with amyloidosis usually have small heart, very small, because that's why they have stroke volume. And they have usually thick heart. Some of them, they don't have thick heart, but we'll not talk about it later. I want you to pick up those with a thick heart, at least 12 millimeter early and the small size. And in this patient, for instance, I show you, he had mildly dilated LV, maybe mildly thick heart or normal thickness. And to be honest with you, this patient has advanced Friedreich ataxia, but it was taken actually by his center as amyloidosis. So like hemochromatosis or Wegener disease, the sarcoidosis, they will give you mildly dilated LV. So look not only at the thickness, but also at the size of the left ventricle by volumes. Also, I think Baha showed you many of these extra cardiac signs. I think if this patient did not have this extra cardiac sign, would maybe make more time to make the diagnosis of Friedreich ataxia. So the extra cardiac clinical sign are really important in the setting of systemic disease, and they will improve the positive predictive value of our echo. When doing an echo, open the light, look at the patient, ask him a question. Don't only look at your image on your screen. And I think he showed you the macroglossial, he showed you the periorbital purpura, he showed you the lesion, skin lesion, the pseudo-hypertrophy, the deltoid. These patients are elderly, so they don't do gym. They mainly have deposit of amyloid in their organ. They have massive nephrotic syndrome, and they have this traumatic bicep structure as shown here in this video from Pablo. So basically, the extracardiac signs are very important in accounting, and that's why this extracardiac come. Why? Because any organ can be involved virtually in this disease. As you can see, the heart or kidney are have equal distribution of involvement. The brain can be involved also, except for the light chain, the central brain. The nerves are mainly for the TTR, the hereditary one, and all of them. And that's why I think this is very important to take it as systemic amyloidosis is really a multidisciplinary, has to have a multidisciplinary team to manage it, and we cannot manage by ourselves. Of course, the cardiology is in the middle of the scenario, but we need really the help of the genetician, the help of the nephrologist, the help of the hematologist, and the help of the neurologist to help us and to see the patient together maybe sometimes, or to refer to him to be able to make the correct diagnosis. So this is another take-home message. Work as a team. Now, by echo, cardiac amyloidosis can be hidden by other disease. And you can see this paper from Gonzalez Esther from Spain. They show you and almost as far as high as 35% that they were taken as actually as hypertensive cardiomyopathy. Other disease, HFpEF, they were taken also, they're misdiagnosed, and they give them Lasix and they go home and they don't think about amyloidosis. Hypertrophic cardiomyopathy is another differential diagnosis, and I will show you few studies about it as far as aortic stenosis and other. So this is just to summarize. There's many studies now, and we have also confirmed in our series from King Faisal that at least 50% of cardiac amyloidosis will present with heart failure with preserved ejection fraction. According to this previous study, at least 13 to 15% with the HFpEF actually have cardiac amyloidosis, TTR, mainly TTR, as initial and etiology diagnosis of the HFpEF. So I want you to think about it every time you have a HFpEF patient. I will show you this case I showed you maybe last time when there was a small webinar. This is 67 years old female. This is again a case that I bring with me from France, from my colleague who was treated this patient for 2 years as a HFpEF patient. But the problem is she does not respond to any treatment despite optimal medical treatment. He was happy, he put her everything, ACE inhibitors, beta blockers. She keep deteriorating, she keep being sick. The pro-BNP keep being high, more than 25,000, and the systolic blood pressure is 11, small, lower and lower. And as you can see here, there is some clue that tells you that something goes with the red flags with the cardiac amyloidosis, which I will summarize later on. You have this small pericardial effusion that is a signature of cardiac amyloidosis in 50% of the case. You have this huge and concentric hypertrophy. Now, sometimes in TTR, you don't have concentric. You can have also eccentric hypertrophy because this patient has also hypertension because they are old. But initially, I mean, you can think it's a blind disease, but I told you about it. It's disease that does not discriminate. It goes everywhere. Look at the interatrial septum. Look at the right ventricular free wall. Look at the valves. Everything is sick. So everything, there is deposit of the amyloid. You can see here the restrictive pattern because this patient came at really very late stage of the disease at 3B. I will talk later about the staging. Decreased S prime, so decreased longitudinal function. By visual assessment, you can see, oh, this patient had normal ejection fraction. And actually, no, she has small ventricle, and the ejection fraction is really moderately decreased, almost 35%. You can see here, the E prime over A prime is very also high, and the pulmonary vein is in favor of LV, increased LV and diastolic pressure. So we don't want to see this patient, because this patient, once she came to our center, we made the diagnosis back home in France, and she died unfortunately despite optimal treatment for her light chain amyloidosis. She died within the 6 months. So the problem of this patient, we keep saying this is not unique. This is not only in France, it's everywhere in the world. And Baha showed you that number. Cardiologists unfortunately will diagnose amyloidosis only in 19% of the case, even in those with advanced stage of the disease. till now. So this is not historical or anecdotal. It happens every day, and probably we are missing. And I have seen maybe 3 patients in King Faisal in 2014, but when I was looked on the data series, they came in cardiogenic shock, exactly like this patient, and they did chemotherapy for her and everything, but did not work at this stage. So it doesn't mean that it's not treatable. Now I will show you another case here that has been taken for actually hypertrophic cardiomyopathy, 80 years old, male with dyspnea, NIHA class 2 and 3. And actually, if you ask him a question, I put it to make it easy for you, history of carpal tunnel. But usually you don't ask, but I told you this is very important and part of the systemic exam of this patient. You can see here again, severe massive thickening of the heart everywhere. You can see here, I'm sorry, I put the left side. I used to work on the Mayo Clinic way. The left heart is here, the right heart is here. You can see the thickness of the valves. Again, same scenario. You have very thick walls, and you have, this is the right, in the superficial view, the right is almost 11 millimeters. The normal is less than 5, and sometimes you don't even see the right free wall. So this is really cannot be at 80 years old hypertrophic cardiomyopathy. Why? Because we don't develop systemic idiopathic familial hypertrophy suddenly at 80 years. This is the rule. I think we should learn that everything it happens. Of course, we can have a cat with many hands and everything, but usually we have to be logical, okay? So this patient has typically wild type amyloidosis. And according to that study from Thibaut Damy, my friend in France, he has been shown 300 patients with LVH more than 15 millimeter, that they were presumed to be hypertrophic sarcomeric cardiomyopathy. And he was able to show, looking at their genetics pattern, that 6% of them actually with a wrong diagnosis has actually familial TTR neuropathy. They have actually the mutation carriers of this TTR gene. And if you look at the cardiomyopathy pattern and phenotype, 5% have actually cardiomyopathy. Now, if you take only the patient more than 55 years old, you can see the more aging you go, the more you have ATTR cardiomyopathy, almost 8%. And if you look at the more than 80 years, you have more actually than 10% having cardiac amyloidosis. So every time you have an elderly patient, don't think about the sarcomeric. You can think of it, but I think this is really, really rare to happen at that late of their life, So I'm hoping that it will, yeah. Now, this is another case of 57 years old female. I remember I told you 35% people were taken as hypertensive disease. And this patient has history of hypertension, but the blood pressure was suddenly normalized. She doesn't even need medication. This is another clue Beha told you about it. She has workup, she came for proteinuria, she has mild dyspnea, NIHA class 2, and the heart rate was normal. The NT-proBNP was 1,800. Usually, in somebody who has hypertension with no decompensation, there is no reason that to have the BNP so high. So this is a clue also to remember that this patient may have other things. And you can see here the ejection fraction is visually normal, but you can see the LA is dilated, and you have some kind of increased brilliance of the IBS. I don't talk much about it because it depends on the gain and the harmonics of your machine. But most of them, this patient had this pattern, which I will talk about it immediately after that. She had this cherry on top that will talk about it. And I want you really, really to remember the other take-home message. This patient had usually a strain, abnormal strain, global strain, less than 20 millimeter, 20%, but they have always that apex, this apical strain, which is relatively more preserved than the basal strain. So this is another clinical scenario. So this patient basically had stage 2 Mayo Clinic cardiac light chain amyloidosis, and she was treated, and she had a good, very good outcome actually, because we take it earlier than the previous patient. Now, this is another patient from King Faisal who was 80 years old, dyspnea class 2-3, since 2 months again. He has also hypertension, like everybody. He has been treating with losartan, old TIA, and no history of chest pain. But you can see his EKG here. You can see that there's some, I wanted to make it as a question because, but probably, unfortunately, I thought I have only very few minutes, so I will just show you the images and you will think about the questions. He has a mild increase on the creatinine, GFR is mildly reduced, and the pro-BNP again is elevated at 3,000. So this patient, if you can look at the echo, it's you can see again, you can see concentric hypertrophy, pretty significant. The LV ejection fraction by visual assessment could be looked normal, but actually is not normal. And I will show you that in this case with small ventricles, you have always to do a Simpson. Otherwise, Otherwise, you will be mistaken and you will think the patient has normal ejection fraction or normal strain. So you can see here we did the AutoEF or the Simpson method, and you can see, I don't know why it doesn't work, this one. Okay, it's where you can see even the RV is a little bit hypertrophy. So this patient again could be taken for hypertensive disease, but actually I want you to look at the other parameter, the diastolic parameter, that can give you also clues that this patient cannot be only have hypertensive disease. He has severely dilated LA. It could be, but as I told you, it's rare. He has restrictive pattern. He has a severe mitral tragus regurgitation leading to high PA pressure and high RA pressure. You have again here this constant sign, small s prime and the small e prime at the Doppler tissue imaging here. So the image was, the question was, I wanted to ask you, it was, is this normal echo? You can guess it is not a normal echo. I was asking people if it's reduced, mildly to moderately reduced ejection fraction 35 to 40 and concentric LVH, or borderline reduced EF, or with increased LV filling pressure and severely dilated LA and significant pulmonary hypertension. And guess what? The time I asked this question, believe me, 50% of the audience respond that this patient has almost normal ejection fraction, because they looked only at the visual assessment and they did not respond 35 to 40. So basically, I want you, the take-home message is to look at the Simpson. Here, the ejection fraction was 38%. To look them all, put the puzzle together, put the global strain, perform it first, and put it together. And again, you can see this typical pattern of abnormal strain with sherry on top, red here and little bit pink. The normal is everything should be red, and the normal value is minus 20%. And moreover, Baha told you about this sign of pseudonormal MFARC pattern in V1, V2, V3, relatively low voltage when you compare it to the LVH by echo. Put always together. When you have an echo, put always the EKG with it, and vice versa. Don't interpret the echo without having your EKG under your eyes. And you can see here, this patient have probably AFib ablation, and it's 50% he told. So we did for this patient, we can, because we had the suspicion, we did the PYP scan, which we'll talk tomorrow about it. And you can see here, it was positive, strongly suggestive, grade 2, score 3 actually by the nuclear, consistent with ATTR amyloidosis. So every time you have somebody with unexplained LVH, elderly patient, more than 13 millimeter of LVH, you have, I think this will be the guidelines, and I think some papers has spoken about it from Dr. Pablo Garcia team, from Patrick Morar in Cleveland, and in United States, Martha Grogan in Mayo Clinic. When you have, and I think there will be like kind of algorithm, anytime you have LVH, we should perform, with the abnormal findings, we should perform PYP scan. We'll talk about it later actually. Let's look at this other case now. I'm sorry, I'm giving you a lot of cases, but I want you to remember at the end of this night that you have many images. Many images talk better than words. So this is an 85 years old man with dyspnea class 2-3 again, systolic murmur since many months. Here again, you are struck by the LVH, important concentric LVH. But what's additional on that, we have this aortic valve that is thickened, calcified, and hardly opening. You can see here, and this is 85. So you can see, okay, this patient has severe aortic stenosis, and that's why he has concentric LVH. This is the most typical cases actually in everyday practice. Everybody of us can see almost 5 AS per week, and the team every morning we talk about aortic stenosis. Now, if you take the number, you have the peak and the mean gradient that are abnormally low when you put it together with the aortic valve opening. 24/14, it's a low gradient. When you look at the aortic valve area measure calculated, it was 1.09 centimeter square, and when you put it according to the body surface area, it was the LVOT-TVI 13, but I will give you the stroke volume. So again, I want you to put together all this information, always in your mind. Put the EKG from one side, put the LV function, the LV pattern, put the valves here, and put the GLS again. So I want you to remember that every time you have LVH, I think GLS is not, it has to be done. It's not something optional. We have to do it for every patient with LVH. And you can see again and again, this is another machine, but it will allows you to see also that there is a sherry on top, and you have the basal and mid decrease of the deformation of this heart. Now, if you calculate the stroke volume, it was using 30 milliliter of CVI, it's 31 milliliter per minute square. So the conclusion of this patient, the impression is, does he have low flow? Can you respond to this question? Low flow, low gradient, significant aortic stenosis. Bilal, I want you to pull out severe cardiac amyloidosis, low flow, low gradient aortic stenosis, and cardiac amyloidosis, or likely C but needs MRI, or likely C but needs PYP bone scintigraphy of the heart. So can you respond, please, to that question? Now I give you many clues. So we know that he has severe aortic stenosis. We know he has low flow. We know that he has low gradient. Do we need something else to decide if he has cardiac amyloidosis or not? Please, can you show me the answer now for everybody? Okay. So this is, I like it also because actually it tells you that we need to talk more about it. And as this patient, of course, everybody agreed that he has aortic stenosis. I showed you by numbers and by images. He has aortic stenosis. It's a significant. He has low gradients and he has low flow. However, do we need the MRI? 22% respond yes. I don't think we need MRI at this point for this patient. We have many clues, but I think we need absolutely a PYP bone scintigraphy to confirm that that this patient has really important cardiac uptake by scintigraphy. So only 25% respond. So probably by tomorrow evening, maybe people will respond by 100%. Now we can take out that question, please, and go back to my. So this is why I'm talking about aortic stenosis, because Baha also gave words about it. He told you that this is a very common presentation of patients. In addition to HFpEF patient, you will see a lot of patients presenting with aortic stenosis and cardiac amyloidosis putting together. You can say this is okay, two diseases for the elderly, so probably they are both associated because of their elderly. There's maybe other reason that we don't know yet, but this is the first time 16 cases were presented from France, were published for the first time in the world in 2016, and they were able to describe the pattern of these 16 cases. They showed that they were more in this case they were surgical in 63 because they didn't know probably they have amyloidosis, but then later the mortality was high by surgery, and they have more likely AFib and low flow, low gradient. And since that publication, I can show you since 2016 many other publications go from all over the world, including until this week. I showed you this is April 2020, another paper from Vienna team, and this one from England team this month, two publications about the prevalence and the outcome of patients with degenerative aortic stenosis and cardiac amyloidosis TTR. So really it's a very hot topic actually. And what I can say about when I read all these papers, basically the prevalence of cardiac amyloidosis in patients with aortic stenosis is around 5%. For those undergoing surgical AVR is between 8 to 16% in those undergoing TAVI. I used to say only put one slide to put around 15%, but because this paper show us this week in European Heart, they said it's about 8%. So I prefer to say it's had almost 200 patients. So this is really a big series, and they found 8% of the population of their patient undergoing TAVI with cardiac amyloidosis. And the paper from the previous one from Castano was 16%, and the paper from England, 250 patients, they found only 13%. So it's almost the same, but let's say in general, it's between 8 to 16% to 13%. Now, the problem that is not resolved, what is the outcome of this patient? Some studies, small studies showed that the association of aortic stenosis and cardiac amyloidosis has worse prognosis than one with aortic stenosis. But this is really controversial, and we are working on a letter to send to the editor, because probably this patient, some team showed that they can benefit from TAVI, they have very good outcome, exactly like the same of aortic stenosis undergoing TAVI. And some other teams said maybe the fact that you have a cardiac amyloidosis, we should maybe look at them carefully, and they have more cardiac complications. So I will not comment on that because we don't know really that's the story. I want you to remember that the red flags for associated cardiac amyloidosis in case of aortic stenosis is markedly thickening LV walls more than the aortic stenosis wanted itself, low stroke volume on most of the times, low flow, low gradient, and this was confirmed actually also in the recent paper from Vienna and from England. Advanced diastolic dysfunction more than the aortic stenosis itself patient. Pericardial effusion, there is no reason the aortic stenosis patient would have pericardial effusion, and impaired longitudinal function as shown here by the longitudinal.
Excuse me, Dr. Dania.
Yes.
I think we need to little bit cut it short, because we're already 13 minutes post our time, and we need to open
Okay,
for
so
call
I will
for
not talk
one or two
about
questions.
GLS because I talked
Sorry for the interruption.
No problem, no problem. I asked actually authorization from Dr. Islam to have a little bit more time because I added a few slides for because of the problem with Dr. Baha, but it's okay. So just to tell you, this is very important, and this is in the guidelines actually to perform for LVH patient. You can see that the pattern could be different from different disease. This is the Fabry disease. You have low strain only on the inferiolateral, whereas in our cardiac amyloidosis is always present as a cherry on top with relative apical sparing, whether the disease is advanced, like this patient who died maybe 3 months later, or there's very good prognosis this patient. You have always this kind of pattern irrespective of the absolute number of the GLS. Now, if you look at that strain and you have this abnormal diastolic patterns, you will have a very good accuracy to diagnose cardiac amyloidosis on this patient. So what are the other clues suggestive of cardiac amyloidosis? I show you here the stroke volume, even in the absence of aortic stenosis, the aortic valve thickenings, the atrial dysfunction, the increase in PA pressure, and the increase of the thickening of the heart. And these are clues for a diagnosis, but also, as I shown here, in prognosis of this patient. And this is the reason why sometimes you have thrombi in the left atrium despite the presence of sinus rhythm. And this, I think, Dr. Kharabsha tomorrow will talk about it. Now, what is the R flag? This is very important slide. The important red flags in echo: severe heart failure contrasting with apparently normal ventricles, atria are enlarged, LV hypertrophy contrasting with relatively low voltage, significant decrease in GLS with relative apical sparing as shown here on these images, markedly raised LV filling pressure, blindly diffuse deposit of the amyloid fibrils, increase of PA pressure, and small pericardial effusion. What is the role of bone scintigraphy of the heart? You stay connected, I hope so, tomorrow, and this part will be discussed by Dr. Hussam Al-Zaftawi tomorrow, I hope. And for those who are not able to attend tomorrow evening, I want you to remember that it's the cornerstone of ATTR cardiac amyloidosis. It can be done, it can be entered by quantitative way or qualitative way. This is a very strong uptake of the myocardium, and this is zero uptake. And when you have grade 2 or 3 uptake, plus the absence of plasma cell dyscrasia, is really diagnosed of ATTR cardiac amyloidosis with a really very important, more 100% of positive predictive value. So really, it's a very important test to perform, but I think tomorrow he will talk about it. When to perform CMR, you respond 25 respond that we need to do? No. Actually, it's sometimes because CMR, exactly that has been shown that it has correlation between LGE by CMR and amyloid deposit. It gives you exactly the same information by echo as done by echo, the morphological, but in a better spatial resolution. And all the pattern of the LGE are possible. You have also increase of extracellular volume expansion and increase of the native T1 mapping. And the red flags for that are basically suboptimal myocardial nulling prior to blood pooling nulling, markedly extracellular volume expansion, global subendocardial or diffuse LGE, the annular typical, and elevated T1 signals. When to do the biopsy for this patient? You have to do always a tissue biopsy when light chain is suspected. It's an emergency, remember, and you have to do it very rarely when ATTR is suspected in the heart, and especially when you don't have other reason to diagnose it. So for the light chain, diagnosis should be always confirmed by biopsy. Biopsy to prove the presence of amyloid fibril in the tissue. Usually we use the rectal or the subcutaneous fat or accessory salivary gland, and rarely the solid organ as a cardiac or renal. You need to show the red Congo and the apple green birefringence. And you have, secondly, to type the original protein. Remember, there's many precursors of this fibril amyloid, so you have to do immunohistochemical test and mass spectrometry to be able to show the region. You cannot treat TTR like light chain amyloidosis. Finally, what are the lab tests to be performed when you have a cardiac amyloidosis? You have to do, of course, the BNP, that anti-proBNP, and the troponin, as I showed you, it helped us a lot. But you have also to rule out light chain amyloidosis by doing serum immunoelectrofixation and urine immunofixation and the ratio of kappa over lambda. 3 of them should be negative. 3 of them, I'm repeating, not only 1 of them, to be able to rule out cardiac amyloidosis and to think of the other disease. And this is, I will not talk about it today, about the prognostic biomarkers, but know that it's very important to stratify this patient. And finally, in summary, where we should look for this cardiac amyloid patient, Baha showed you in HFpEF patient, in TAVI patient population, in SAVI population, in somebody who has even HFrEF population, in somebody who has presumed hypertrophic cardiomyopathy with no reason, in somebody who has massive proteinuria, nephrotic syndrome, he has somebody who has multiple myeloma, 30%, and maybe other referrals or genetic departments. Now, why all these imaging are important? Because it will help us not only to make diagnosis, but it will help us also to choose the patient who will be treated later on. And I think Harabsha, Dr. Sulaiman tomorrow will talk about it. We cannot treat everybody, obviously. So I will finish my talk by telling you this is, and I will not spend a lot of time tomorrow. I think Baha will take it again. When you have a very high suspicion, clinical or EKG and echo and blood test, you have a suspicion of cardiac amyloidosis. The first things to do is to do to do a nuclear scan. If it's positive in the left side, then you have immediately to perform the gamma patty monoclonal workup, as I told you, the immunofixation, the free light chain, and the proteinuria in the urine. If this is negative, then you have in position of TTR amyloidosis. In this case, you have to do genetic test. If you have genetic test negative, then you have in phase on wild type TTR, most likely. And if it's positive, you have hereditary TTR amyloidosis. Now, if the monoclonal gammopathy is positive, then you have immediately to perform tissue biopsy, not heart biopsy, but tissue biopsy. If it's positive, then you think that is light chain amyloidosis and you treat her immediately. If it's negative, it could be no amyloidosis, or TTR amyloidosis, other type of amyloidosis. And this is in the presence of negative scan grade 0 or 1. In this case, if you still have suspicion, then you have to do tissue biopsy, maybe the heart, but tomorrow probably Baha will repeat it later. So a take-home message, work as a team, have a high index of suspicion. If you don't think it, you will not diagnose it. Recognize the disease very early. Look for clues in the medical history. Look for clues on the EKG. Look for clues on the echo, and order bone scintigraphy very easily, and perform also the protein electrophoresis. And I want you to finish. Thank you very much. And we see only what we're looking for, and the eye does not see what the mind does not know, and looking forward to come back from virtual life to real life. Thank you very much.
Thank you very much, Dr. Dania, Dr. Baha, Dr. Adil. I think we have one question between the questions, which is, but I hope you can answer it in a very, very concise manner. What are other differentials for cherry on top, or cherry on top for other than amyloidosis?
Okay, actually, I showed you many patterns because I was very fast. You told me to go fast, so I could not explain very well. Basically, virtually all disease with LVH or other disease, usually for some reason, the basal levels are decreased. We know that. So basically, for some reason, the shear wave stress start on the basal level of the heart, and then it goes slowly. Now, what the difference between amyloidosis and the other, even aortic stenosis, gives you also this kind of pattern. But the difference is the ratio between the apex and the base that is different, and is more than 2.1 on the case of amyloidosis. So when you have GLS, you have to calculate also the ratio, which I couldn't talk about it, ratio between the base and the apex, which should be more than 2.1. In other disease, you can have this pattern, but the ratio would be lower than that. Baha, you can comment on that if you want.
Yeah.
No? Okay.
I think the link with Dr. Baha. Is Dr. Adil still with us? Okay. So
yes, I'm here. Yes.
Okay, Dr. Adil, I think we need to conclude, so you can take the lead.
Okay, thank you very much, Dr. Baha, Dr. Dania, and Dr. Kamal for this very interesting session. It was a bit too much for me as a cardiac surgeon. You know, where the intellect for cardiac surgeons is a little bit lower than the cardiologists. But you know, it was very informative, and it was interesting. And as you know, I think you know, the great pretender. I think we should really look for it a lot. You know, Dr. Dania, when she was presenting the low flow, low gradient cases, I could recall many of those cases that we really did not look for or did not suspect that these patients could have amyloidosis, and we did TAVI for them, or we did SAVR for them. But you know, working as a team and having establishing these connections with the experts like Dr. Dania and Dr. Baha from King Faisal Specialist Hospital, and other experts from around nationally and internationally, we could really help our patients in a better way than working alone. Thank you very much, everybody. The attendance today was marvelous, was fantastic. 1,153 people heard you speak, Dr. Dania and Dr. Baha. We thank you very much. حقيقة يعني it's really impressive. You know, I did not really think that we would have more than 1,000 people attending a talk about cardiac amyloidosis, but it seems that cardiac amyloidosis is something that people are interested in hearing about and learning more about. And last but not least, I would like to thank the Saudi Heart Association for this wonderful effort to with these webinars and different topics. And I would like to thank Pfizer for sponsoring this event, and looking forward to further collaboration with the Saudi Heart and with Pfizer. Thank you very much, everybody.
I have one small comment, if you allow me, Dr. Adil.
Yes.
I would just like to remind everybody that tomorrow, same time, there is a continuity of this important topic and two extremely eminent speakers. So don't miss it. Be on time tomorrow, 10 p.m. Saudi time. Assalamu alaikum.
Thank you very much, Dr. Gawan. Thank you.
Assalamu
Goodbye. Ma'assalam.